All right, everyone, get ready for a deep dive. We're tackling some tough microbiology concepts today, straight from Exam A. Questions 21 through 30, to be exact. We're not just aiming for the right answers here. We're going to figure out the why behind them.
Yeah, exactly. It's all about bridging that gap between textbook knowledge and real-life scenarios.
It's crucial for anyone working in microbiology, especially with an exam from Gemini. So let's jump right into question 21. This one's all about live attenuated versus inactivated vaccines, a topic that's so important for patient care, especially for folks with compromised immune systems.
Absolutely. This is where the choice of vaccine can really make a difference. The question asks us to pick out the live attenuated vaccine from this list: Zostavax for VZV, Abrysvo for RSV, Avexy for RSV, or Shingrix for VZV. They've even thrown in 2 VZV vaccines to make us think.
Oh, for sure. Classic Gemini move. Before we even look at those options, though, can you remind us what the core difference is between live attenuated and inactivated vaccines?
Okay, so imagine a live attenuated vaccine is like a boot camp for your immune system.
Yeah.
It's exposed to a weakened version of the virus, letting it build up defenses, but without the risk of getting really sick. But with an inactivated vaccine, it's more like showing the immune system a mugshot of the virus. It knows what to look for in attack if it ever encounters the real deal.
I like those analogies. So why is this distinction so important when we're talking about someone who is immunocompromised?
Because, well, with a live attenuated vaccine, there's a small chance, it's not huge, but it's there that the weakened virus could still replicate too much in someone whose immune system isn't that strong. Inactivated vaccines are much safer for them because there's no live virus at all.
That makes sense. So back to our options. We have Zostavax, Abrysvo, Avexy, and Shingrix. Which one's the live attenuated vaccine?
It's Zostavax. It's the only one on that list that actually contains a weakened version of the virus. Abrysvo and Shingrix are both subunit vaccines, meaning they only have pieces of the virus, not the whole thing. And Avexy, well, that's not even a real vaccine. Probably just there to throw us off. Gemini loves those curveballs.
Always testing us. So the examiners really wanted us to understand vaccine types and how that ties into patient safety. What did they want us to take away from the short lecture on this topic?
The short lecture dives into the safety aspect, reminding us that live attenuated vaccines, while effective, can be a risk for immunocompromised patients. Inactivated vaccines are the safer choice for those folks because there's no chance of the virus replicating out of control.
It's a delicate balance, weighing the benefits against the risks, especially for vulnerable patients. What about the long lecture? Anything extra in there?
Yeah, the long lecture takes each of those vaccine options from the question and breaks them down, making it clear whether they're live attenuated or inactivated. It really focuses on the potential confusion around Zostavax and Shingrix, since they both target VZV.
Ah, so they're anticipating that someone might think, hey, they're both for the same virus, they must work the same way.
Exactly. The long lecture really emphasizes that, yes, both are for VZV, but Zostavax is live attenuated, while Shingrix is a subunit vaccine. Big difference when you're choosing a vaccine for someone who's immunocompromised.
It's a good point. We can't just focus on the target. We have to understand the specific formulation and what that means for the patient. Now, listener, does the Gemini Advanced Reasoning Model's explanation make sense to you? Do you agree that Zostavax is the right answer, and did you find their explanation clear? Now let's move on to question 22. This one feels like we're solving a mystery using serology results to piece together a patient's history with hepatitis B.
It's like serology is telling a story that the patient might not even know. We've got a 40-year-old man, he's not showing any symptoms, but his HBV serology is, well, it's pretty interesting.
All right, lay it on us. What's the serology telling us?
Okay, so 20 years ago, this guy was vaccinated against hepatitis B. His serology back then showed negative HBsAg, positive anti-HBs, over 1,000 IUL, and negative anti-HBcore. Now fast forward to today, and his latest tests show negative HBsAg, positive anti-HBs, but it's lower, 560 IUL, and a strong positive anti-HBcore.
Okay, so that anti-HBcore popping up positive, that's the new piece of the puzzle. Can you remind us what that means, especially for someone who's been vaccinated?
Right, so anti-HBcore, that's the antibody to the hepatitis B core antigen. It means the person's been exposed to the whole virus. This is important because the vaccine, it only has the surface antigen.
So finding anti-HBcore means he encountered the actual virus sometime after his vaccination.
That's right, and if his immune system hadn't been prepared by that vaccine, he might have had a full-blown hepatitis infection.
But he's got no symptoms. Is that just because his vaccine was that good?
It did its job, that's for sure. It basically trained his immune system to fight off the virus so well that he probably had what we call a subclinical infection. His body dealt with the virus without him even knowing it, but it still produced those antibodies.
Wow, so he's walking around immune, maybe even protecting others, and he doesn't even know he had a brush with hepatitis B. That's pretty wild. What was Gemini trying to teach us with the short lecture on this question?
The short lecture emphasizes that anti-HBcore antibodies, they show exposure to the whole hepatitis B virus, not just what's in the vaccine. It explains that this change from negative to positive strongly suggests a past infection, even though the vaccination was successful.
It's a good reminder that even vaccinated people can still encounter the virus, but thanks to the vaccine, their immune system is ready to fight. What about the long lecture? Did that offer any more insight?
The long lecture goes all in on explaining all the HBV serology markers, what they mean, how they connect to different stages and types of infection. It walks us through this patient's results step by step, highlighting how the changes over time point to that subclinical infection.
Like a personal tutor for serology interpretation.
Yeah.
Now, listener, I want to hear from you. Does the Gemini Advanced Reasoning Model's explanation make sense? Do you agree with their conclusion that this is a subclinical HBV infection based on these serology results?
Yeah.
All right, let's switch gears to question 23. This one takes us on a little trip to Thailand. We've got a 21-year-old student who's having some post-travel health issue.
Gotta have a travel-related case on a microbiology exam. It's practically tradition.
You're telling me.
Yeah.
This case really makes us use those epidemiological clues, incubation periods, clinical presentation, all that, to figure out what's going on. Our student's been back from Thailand for about 3 weeks, and now she's got jaundice, which is a pretty classic sign of hepatitis. But the question is, which one? We've got hepatitis A, B, C, even yellow fever on the table.
And to make things more interesting, she's up to date on her routine vaccinations, but didn't get any extra shots before the trip. Oh, and she was enjoying the local food and drinks and had unprotected sex with a couple of different partners.
So multiple potential transmission routes. Where do we even start?
Well, the incubation period is our first clue. That's how much time passes between exposure and getting symptoms. She got sick about 3 weeks after getting back, so the exposure probably happened while she was in Thailand.
So that rules out yellow fever, right? That one's got a really short incubation period.
Yeah, only 3 to 6 days. But the other options, their incubation periods could all fit, right?
That could, yeah.
Hepatitis A is around 28 days on average. Hepatitis B can be 60 to 90 days. And hepatitis C can be even longer. But remember, incubation period is just one piece of the puzzle. What about her vaccinations?
Good point. In most places, routine vaccinations would include hepatitis B. So if she responded well to that, it's probably less likely.
Right. And don't forget about the whole epidemiology side of things. Trying all sorts of foods and drinks, especially in places where sanitation might not be the best, that significantly raises the risk of hepatitis A.
And while unprotected sex could transmit hepatitis B or C, it's less common for acute infections, especially hepatitis C, which is usually spread through blood.
Yeah, that's a good point.
So we're leaning towards hepatitis A as the most likely culprit.
I think considering everything, the incubation period, her vaccination status, and how common hepatitis A is in Thailand, especially with food and water, it seems like the most logical conclusion. But in a real-life situation, we wouldn't jump to a conclusion, right? We'd order more tests to be sure.
For sure. Confirm that diagnosis.
Yeah.
What about Gemini's take on this question? What did they want us to learn from the short lecture?
The short lecture really hammers home the importance of using those epidemiological clues to figure things out. It points out that hepatitis A is really common with contaminated food and water, which fits perfectly with our student's trip to Thailand.
It's reminding us to think about the context of the exposure, not just the symptoms themselves. What about the long lecture?
Okay, so the long lecture goes deep into those incubation periods for each virus and compares them really carefully to when our student started showing symptoms. Remember, it was about 70 days after her potential exposure. It lays out the typical ranges for hepatitis A, B, and C, and even yellow fever, showing us how they match up to the case.
So it's really making us think critically about the timing of the infection.
Exactly. And it even points out how easy it would be to pick hepatitis B because the incubation period kind of lines up. But in the end, the risk factors and her likely vaccination status make hepatitis A much more probable.
Yeah, it's a good reminder. Incubation period is a big clue, but it's not the whole story. We have to look at the whole picture. Risk factors, vaccinations, how common different infections are in the area. So, listener, I want to hear from you. Does the Gemini Advanced Reasoning Model's focus on epidemiological clues make sense to you? Would you have tackled this case the same way, putting together all the pieces to reach the most likely diagnosis? Now, for question 24, we're going to the Alps. Beautiful scenery, right? But this time, the view isn't so great. We've got a 64-year-old woman who went on a hiking trip in the Austrian and Italian Alps 10 weeks ago.
The Alps. Great place to visit, but it does come with some unique infectious diseases.
For sure. 6 days before ending up in the hospital, she started having headaches and a fever. 3 days before, she became really drowsy and less responsive.
Sounds pretty serious. What did they think was going on at first?
Initially, they thought it was a urinary tract infection and started her on intravenous cefuroxime.
Cefuroxime. Okay.
Yeah. But things took a turn for the worse. On her first night in the hospital, she had convulsions and ended up in the ICU with reduced consciousness.
Oh, wow. Convulsions. That definitely points to something affecting the central nervous system. Did they do any more tests?
They did. Brain imaging showed swelling in her left, temporal, parietal, and frontal lobes. Her CSF analysis showed normal total protein and glucose, but her leukocytes were elevated, 375 by 106 per liter.
With those findings, you've got to think about viral encephalitis. And the question asks us to figure out the most likely virus. The options are enterovirus, JC virus, tick-borne encephalitis, or HSV1.
With that trip to the Alps, I bet you're thinking tick-borne encephalitis, right?
Well, it did cross my mind for sure. It fits with the travel history. But you know what? The actual answer is HSV1.
Really? But HSV1 is so common. Shouldn't we be considering that first, even without the Alps trip?
You're absolutely right. While tick-borne encephalitis is a concern in that region, HSV1 is the most common cause of sporadic encephalitis everywhere. And the clinical picture, the fever, headache, altered mental status, and seizures, it all fits with HSV1 encephalitis.
So this question is making us think carefully about the travel history versus how common a disease actually is. It's easy to get sidetracked by something rare just because of where the person went. What did Gemini want us to learn from the short lecture on this?
The short lecture acknowledges that tick-borne encephalitis makes sense based on her trip, but it reminds us that HSV1 is statistically more common overall. It's subtly nudging us to consider HSV1 even with the Alps trip.
It's reminding us not to get distracted by those rare possibilities. Common things are common for a reason. What about the long lecture? Any extra nuggets of wisdom in there?
The long lecture is really insightful because it directly addresses the struggle between the Alps trip suggesting tick-borne encephalitis and the fact that HSV1 is just way more likely. It recognizes tick-borne encephalitis as a real possibility, but then explains why we can't rule out HSV1.
Like it's having a debate with us.
Right. It points out that those initial symptoms of fever, headache, and altered mental status, they're pretty general, could be either HSV1 or tick-borne encephalitis.
So the initial presentation doesn't really help us tell them apart.
Nope. But then it points to the convulsions as a really important clue. Seizures can happen in different types of encephalitis, but they're a hallmark of HSV1 encephalitis. The long lecture also highlights that HSV1 encephalitis usually affects the temporal lobe, which matches the brain imaging findings in this case.
So we do have some things that point more towards HSV1. What about the CSF findings, though? Didn't those look a bit different from what we'd expect with HSV1 encephalitis?
You're right. The long lecture acknowledges that the normal protein level isn't typical for HSV1 encephalitis. Usually it would be elevated. But it explains that normal protein can happen, especially early on, and that CSF protein levels can fluctuate depending on the stage of the illness and the patient.
So we can't eliminate HSV1 just because of that normal protein.
Right. And then it reminds us that, unlike tick-borne encephalitis, which is pretty localized, HSV1 is everywhere. Anyone could potentially get HSV1 encephalitis regardless of travel history.
So in real life, we'd probably have both tick-borne encephalitis and HSV1 on our list of possibilities and do more testing to figure out the actual cause.
Exactly. It's rarely black and white.
True. All right, listener, what are your thoughts? Do you agree that HSV1 is the most likely cause, even with the Alps trip? Or would you have initially leaned towards tick-borne encephalitis? Now let's head to a war zone in Ukraine for question 25. This one is all about multi-drug-resistant Acinetobacter baumannii. It's a real problem in healthcare settings and war zones.
Yeah, it's notorious for developing resistance to multiple antibiotics. In this case, the only thing this strain is sensitive to is the combination of ampicillin and sulbactam. The question wants us to explain why that combo works.
So we need to understand why that particular combination is effective against a bug that's so good at resisting antibiotics.
Exactly, and the key lies in understanding sulbactam. It's not an antibiotic itself, it's what we call a beta-lactamase inhibitor. It's like a shield for ampicillin, stopping it from getting destroyed by those pesky beta-lactamases that the bacteria produce.
So sulbactam is like ampicillin's bodyguard, making sure it can get to work and kill those bacteria. But why does this combo work so well against this particular Acinetobacter?
Well, Acinetobacter baumannii is known for producing a specific type of beta-lactamase called OXA beta-lactamase, which is really good at breaking down penicillins like ampicillin. And guess what? Sulbactam happens to be really good at inhibiting that OXA enzyme.
So it's all about teamwork. What did Gemini want us to get from the short lecture on this topic?
The short lecture really emphasizes the fact that sulbactam is a beta-lactamase inhibitor, and that's what makes the combination work, not any antibiotic activity of sulbactam itself. It clarifies that ampicillin does have some activity against Acinetobacter, but that activity is really weakened in these multi-drug resistant strains.
Ampicillin needs its trusty sidekick. What about the long lecture? Did that give us a deeper dive into the case?
The long lecture gives us a great overview of Acinetobacter baumannii, explaining why it's so good at developing multi-drug resistance, especially in healthcare settings and war zones. It explains that this resistance is often due to those OXA-type beta-lactamases we were talking about.
So it's like resistance is built into their DNA.
Exactly. And the long lecture goes on to carefully explain how both ampicillin and sulbactam work, really emphasizing that sulbactam's main job is to protect ampicillin from those OXA enzymes.
It's like a step-by-step guide to how this dynamic duo takes down the resistant bacteria. So listener, what are your thoughts on the Gemini Advanced Reasoning Model's explanation? Does their focus on sulbactam's role in inhibiting the OXA beta-lactamase make sense to you? All right, time for question 26. This one delves into the world of PK/PD, or pharmacokinetics and pharmacodynamics. Specifically, it's asking about the key PK/PD parameter for vancomycin.
Oh yeah, this is fundamental stuff, but vancomycin can be a bit tricky when it comes to PK/PD. It doesn't quite fit the usual categories.
The options are Cmax-Minic, FTMIC, TMIC, and IUCMIC. Could you remind us what those even mean and how they relate to different antibiotics?
Sure. So think of PK/PD as figuring out how the drug moves through the body and how it interacts with the bacteria. Some antibiotics are what we call concentration-dependent killers. They work better as the concentration goes up. For those drugs, Cmax-E is a good indicator. Then we have time-dependent killers, where it's more about how long the drug concentration stays above the MIC rather than how high it gets. That's where FTMIC or TMIC come in.
Okay, so where does vancomycin fit in?
That's the thing. It's a bit of a hybrid. It's considered time-dependent, but its most relevant parameter is actually AUCMIC. And that's because AUCMIC shows the total drug exposure over time, not just the time above the MIC. It gives us a more complete picture.
So for vancomycin, it's not just about being above the MIC, it's about hitting those bacteria hard and keeping up the pressure over time.
Yeah, it's like a 1-2 punch. What was Gemini going for with the short lecture for this question? It really emphasizes that IUCMIC is the most reliable way to predict how well vancomycin will work. It explains that IUCMIC correlates better with clinical outcomes than other PK/PD parameters.
So it's pushing us to think beyond those simple categories of time-dependent versus concentration-dependent and really consider the unique characteristics of each antibiotic.
Absolutely. And the long lecture goes even deeper, explaining all those different types of bacterial killing, concentration-dependent, time-dependent, AUC-dependent, with examples for each category.
Like a cheat sheet for understanding antibiotic mechanisms.
Right. And it does a great job of explaining why IUCMIC is the key parameter for vancomycin, even though it's generally considered time-dependent.
So why is IUCMIC so important for vancomycin?
Because it takes both time and concentration into account, giving us a much more accurate picture of how vancomycin works over time. It explains that AUC, or the area under the concentration time curve, reflects the total drug exposure over a dosing interval, and dividing that by the MIC tells us how much drug the bacteria are actually seeing.
So it's not just about how long the drug concentration stays above the MIC, but also about the total amount of drug those bacteria encounter.
Exactly. And it points out that tons of studies have consistently shown that IUCMIC is the best way to predict whether vancomycin will be successful in treating an infection.
So it's not just a theory, it's based on real-world evidence. Now, listener, I want to hear your perspective. Does the Gemini Advanced Reasoning Model's explanation of AUCMIC as the key parameter for vancomycin make sense to you? Okay, on to question 27. This one throws us a common challenge: adjusting dosages for patients with kidney problems.
Yeah, this is crucial. It's where microbiology meets pharmacology and patient care.
We can't forget about the patient as a whole. So we have an 82-year-old man with a skin infection. It's caused by Pseudomonas aeruginosa that's sensitive to ciprofloxacin. He was initially prescribed 500 milligrams of ciprofloxacin twice a day, but his eGFR is only 21 millimolin, 1.73 milli2.
Ah, that's a red flag for sure. With an eGFR that low, we have to be super careful with ciprofloxacin. It mostly gets eliminated through the kidneys, so if they're not working well, the drug can build up and cause problems.
The question left us to choose the right ciprofloxacin dose for this patient, considering his kidney function. The options are 250 milligrams twice a day, 750 milligrams once a day, 500 milligrams twice a day, or 500 milligrams once a day. What do we do here?
Well, we can rule out 750 milligrams once a day right away. Way too high, even for someone with healthy kidneys. And 500 milligrams twice a day was the initial dose before we knew about his kidney function, so that's out too.
Okay, so it's down to 250 milligrams twice a day or 500 milligrams once a day.
And this is where it gets a bit tough. Both of those options are a lot lower than what he was initially prescribed, which makes sense because of his kidneys. But if we're just going by his eGFR, which is really low, I probably lean towards 250 milligrams twice a day.
But the answer key says 500 milligrams once a day is the right choice. Are you saying they might be wrong?
I wouldn't say wrong exactly. Maybe there's some information missing from the question or some specific guideline recommendations they didn't give us. But just based on what we have, 250 milligrams twice a day seems more prudent to me, considering how low his eGFR is.
Always good to remember that even answer keys can be fallible. What did Gemini want us to take away from the short lecture for this one?
The short lecture focuses on the importance of adjusting antibiotic doses when someone has kidney problems. It specifically says that for someone with an eGFR as low as this man's, 250 milligrams of ciprofloxacin twice a day would generally be the right adjustment. But it also reminds us that you always have to consider the patient's individual situation and overall health.
So it's all about personalized medicine, even with guidelines. What about the long lecture? Any more guidance there?
Yeah, the long lecture explains exactly why we need to adjust ciprofloxacin dosages for people with kidney issues. It says that ciprofloxacin is mainly eliminated through the kidneys, so when they're not working well, the drug can build up and potentially cause side effects. It also gives specific recommendations for different levels of creatinine clearance.
So it's giving us a framework for tailoring those adjustments.
Right. And it reminds us that while guidelines are important, they should always be considered in the context of the individual patient.
It's a call for critical thinking, for sure. So, listener, what's your take? Do you agree with the Gemini advanced reasoning model that 500 milligrams of ciprofloxacin once a day is the correct dose for this patient? Or do you share our concerns about potential toxicity with that low eGFR? All right, let's move on to a case that emphasizes knowing your bugs. Question 28 introduces us to Erysipelotrix rhizopatheae, a bacterium that can cause skin infections.
It's not as common as some others, but it's one to keep in mind, especially in people who work with animals. This case involves a butcher with a hand infection.
The question is, would dalbavancin be a good choice for treating this bug?
To answer that, we need to know a few things about Erysipelotrix rhizopatheae. First, it's gram-positive. But here's the kicker. It's naturally resistant to vancomycin.
Wait, vancomycin? That's like the go-to drug for so many gram-positive infections.
I know, right? It's a bit of an oddball.
So if it's resistant to vancomycin, what about dalbavancin?
That's the clever part of this question. Dalbavancin and vancomycin, they're both in the same class of antibiotics called lipoglycopeptides. So if a bacterium resists vancomycin, chances are it'll resist dalbavancin too.
Ah, so the answer is no, dalbavancin wouldn't be a good choice for this infection.
Exactly. Knowing your bug's resistance patterns is super important. What did the short lecture say about this? The short lecture highlights that key fact. Erysipelotrix rhizopatheae's natural resistance to vancomycin. It reminds us that since dalbavancin is in the same class as vancomycin, resistance to one often means resistance to the other.
It's like, don't miss this crucial detail. What about the long lecture?
The long lecture actually walks us through the thought process for this scenario. It acknowledges that dalbavancin is registered for skin infections, which might make it seem like a good option.
So they're trying to trick us.
All right. But then it drops the bomb. Erysipelotrix rhizopatheae is resistant to vancomycin, and that's specifically mentioned in the source material, so it's a big deal. And because of that, dalbavancin is off the table.
It's a reminder that we have to pay attention to those little details, even in the source material.
Absolutely. The long lecture goes on to say that, according to Dutch sources, penicillin is the preferred treatment for Erysipelotrix rhizopatheae infections.
So we're not only learning what not to use, but also the best treatment option based on the guidelines.
Exactly. And it even mentions that a lot of times Erysipelotrix infections can clear up on their own without any antibiotics.
That's interesting. Sometimes the best treatment is just letting the body do its thing.
It's a good reminder that not every infection needs to be treated aggressively.
All right, listener, what do you think? Do you agree with the Gemini advanced reasoning model that erysipelathrix ruseopathia's resistance to vancomycin makes dalbavancin a no-go? Okay, let's tackle question 29, which is all about optimizing exposure to those beta-lactam antibiotics.
It's a balancing act, right? We want to maximize their effectiveness without causing unnecessary harm.
Totally. The question is simple. Which dosing strategy increases exposure to beta-lactams the best? We've got 4 options. Shorten the dosing interval, but keep the dose the same. Extend the dosing interval, but keep the dose the same. Keep the dosing interval the same, but increase the dose. Or extend the dosing interval and increase the dose.
The key here is remembering that beta-lactams are what we call time-dependent killers. That means how well they work mostly depends on how long their concentration stays above the minimum inhibitory concentration, or MIC, of the bacteria.
So it's not about giving a huge dose all at once. It's about maintaining a steady level above that critical point.
You got it. To do that, the best way is to shorten the dosing interval while keeping the same dose per administration.
So instead of one big dose every 8 hours, maybe we give smaller doses every 6 hours.
Exactly. That way, you avoid those big dips in concentration and make sure the drug stays above the MIC longer, which is super important for beta-lactams.
It's like a constant stream of antibiotic keeping the pressure on those bacteria.
Perfect analogy.
So what was Gemini trying to emphasize with the short lecture for this one?
The short lecture is super straightforward. It just states that shortening the dosing interval while keeping the dose the same is the most effective way to increase beta-lactam exposure. It really drives home that time above MIC concept.
Short and sweet. What about the long lecture? Did that expand on this idea?
Yeah, the long lecture really unpacks the idea of time-dependent killing and how it's different from those concentration-dependent antibiotics. It points out that with beta-lactams, just giving a higher dose doesn't really improve their effect.
So it's not about hitting the bacteria as hard as possible. It's about that consistent exposure over time.
Exactly. It even introduces this concept of FTMIC, which is the percentage of time that the free drug concentration stays above the MIC. This is really important because it reminds us that only the unbound drug can actually get to the bacteria and do its job.
It's like a more nuanced way of looking at drug exposure and effectiveness.
Right. The long lecture then breaks down all those other dosing strategies, explaining why they're not as effective. It points out that extending the dosing interval, whether you keep the dose the same or increase it, actually decreases the time above the MIC, making the antibiotic less effective overall.
So it's really showing us why that shorter interval is the best approach.
Yeah, and it wraps up by saying that shortening the dosing interval while keeping the same total daily dose is the best way to maximize those bacteria-killing effects and minimize side effects.
It's all about finding that balance. All right, listener, what are your thoughts? Does this idea of shortening the dosing interval for beta-lactams make sense to you, given what you know about how these antibiotics work? And finally, we've reached question 30, which takes us into the world of public health reporting. This one's all about a lab using PCR to test for Shiga toxin-producing E. coli, also known as TEC.
It's a great example of how lab testing connects to the bigger picture of keeping people safe from infectious diseases.
The question describes a lab that's looking for 4 specific genes: SHTF1, ST2, SSCV, and E. And the question asks, which one of those genes, if it's the only one that comes back positive, would they need to report to the public health authorities in the Netherlands?
So we need to figure out which gene is the biggest red flag, the one that indicates a STEC infection that's a real threat to public health.
Right. It's not enough to just know that those genes are associated with STEC. We have to understand what they actually mean for the patient and for public health.
Yeah, exactly. So let's break those genes down one by one. First up, we've got Zostavax1 and Zostavax2. These are the genes that code for Shiga toxins, and those are the things that really make SEC dangerous.
Shiga toxins can cause all sorts of problems, right? From diarrhea to more serious things like hemolytic uremic syndrome or HUS.
Which would be really serious.
Yeah, not something you want to mess around with. So are both Zostavax1 and Zostavax2 equally important when it comes to reporting?
Well, not exactly. While they both mean the bacteria can produce Shiga toxins, STEC strains with the SIGA2 gene tend to cause more severe disease. They're more likely to lead to those serious complications.
Okay, so SIGA2 is like the bigger threat. What about SV and E?
SAV, that one codes for a protein that's part of the bacteria's type 3 secretion system. Basically, it's like a little needle that helps the bacteria inject toxins into our cells.
So it's involved in delivering those toxins, but it doesn't actually code for the Shiga toxins themselves.
Right, it's a helper, not the main culprit. And then there's E, which codes for a protein called intimin. Intimin helps the bacteria stick to the lining of our intestines, which makes it easier for them to cause an infection.
So SV and E, they both contribute to making us sick, but they're not directly responsible for the Shiga toxin.
You got it.
So it sounds like CG2 is the one we'd be most concerned about and want to report. But is there anything else we need to think about, especially when it comes to those reporting guidelines?
Ah, that's a great question. And this is where things get a little complicated, especially in the Netherlands. The IVM, their Public Health Institute, made a change to their SEC reporting guidelines after 2016. They started looking at SEC isolates that only have CG1 differently.
Oh, interesting. What changed?
Here's the thing. If a STEC isolate is only positive for CG1 and negative for SV, it doesn't have to be reported anymore.
Hold on. So even though CK1 means the bacteria can make Shiga toxin, they might not always report it.
That's right. It might seem a bit strange, but that's how the Dutch guidelines work now.
So knowing those specific guidelines is super important. What's the thinking behind that change?
Well, the RIVM decided that STEC isolates that only have the STECTEX1 gene and don't have SV, those usually cause milder illness compared to the ones with STEC2. They're just not as much of a public health threat.
I see. So not all STEC infections are the same in terms of how dangerous they are.
Exactly. The short lecture for this question really drives home that point about STECTEC2 being the most important marker.
Like it's saying, this is the one you really need to pay attention to. What about the long lecture? Did that add anything else about the reporting guidelines, especially in the Netherlands?
Yeah, the long lecture does a good job of addressing the trickiness of this question. It points out that finding only one positive gene is kind of a made-up scenario. In a real lab, they would test for all 4 genes at the same time.
So it's more of a hypothetical situation to make us think about the genes individually.
Yeah, and then it reminds us about that important change in the Dutch guidelines after 2016. It really emphasizes that isolates that are only positive for STI1 and also negative for SV don't need to be reported anymore.
It's good to see how guidelines change as we learn more and as our understanding of disease risk evolves. What was the reason behind that change, according to the long lecture?
It explains that those STI1 only isolates, the ones without SV, they're usually associated with less severe illness compared to the ones that have STIC2. So the RVM basically decided they're not as big of a priority from a public health perspective.
Makes sense. Not all SECTEC infections are created equal. Some are much more likely to cause serious problems. The long lecture also clarifies why E and SC, even though they contribute to how nasty the bacteria are, aren't enough to trigger a report on their own.
Yeah, they're not specific to STEC, and they don't necessarily mean the bacteria are producing Shiga toxin, which is the real concern.
So it's important to take all of that into account, the genes, what they mean clinically, and those local guidelines to make the right call.
Absolutely.
All right, listener, what are your thoughts on the Gemini Advanced Reasoning Model's explanation for this question? Does their breakdown of the Dutch guidelines and their focus on SPINOS2 as the most important marker make sense to you? Now, let's move away from public health reporting and go back to a clinical case. Question 27 focuses on something that comes up all the time, adjusting antibiotic doses for patients with kidney problems.
It's a perfect example of how microbiology is connected to pharmacology and taking care of patients.
We have to think about the whole patient, not just the bug. In this case, we have an 82-year-old man with a skin infection caused by Pseudomonas aeruginosa. Good news is, it's sensitive to ciprofloxacin, but his EGFR is only 21 millimolar, 1.73 millino, which is pretty low.
Yeah, that low EGFR is a definite red flag. It means his kidneys aren't working as well as they should, and we need to be really careful with ciprofloxacin. It's mostly cleared through the kidneys, so if they're not functioning well, the drug can build up and cause problems.
The doctor initially prescribed 500 milligrams of ciprofloxacin twice a day, which is a standard dose for someone with healthy kidneys. But with his kidney function, we need to adjust that.
Absolutely. The question asks us to pick the right ciprofloxacin dosage for this patient, considering his kidney function. The options are 250 milligrams twice a day, 750 milligrams once a day, 500 milligrams twice a day, or 500 milligrams once a day.
Well, we can definitely rule out 750 milligrams once a day right away. That's way too high, even if his kidneys were working perfectly. And we know that 500 milligrams twice a day was the initial dose before we knew about his kidney function, so that's out too.
Agreed. So we're left with 250 milligrams twice a day or 500 milligrams once a day. Both of those are a lot lower than what he was originally prescribed, which is a good starting point.
So which one do we choose?
This is where it gets a bit tricky. Both of those are big dose reductions, which makes sense because of his kidneys. But if we're just going by his eGFR, which is really low, I'd lean towards 250 milligrams twice a day just to be on the safe side.
But the answer key says the correct choice is 500 milligrams once a day. Are you saying it could be wrong?
I'm not saying it's definitely wrong, but it does make me wonder, maybe there's some information missing, or maybe there are some very specific guidelines that they didn't include in the question.
It's a good reminder to always think critically, even when we're looking at an answer key.
Absolutely.
So what did Gemini want us to take away from the short lecture for this question?
The short lecture stresses how important it is to adjust antibiotic dosages for people who have kidney issues. And it specifically mentions that for someone with a low eGFR, like our 82-year-old patient, 250 milligrams twice a day is usually a good adjustment. But it also wisely says that you should always consider the individual patient and their overall health when making those decisions.
Personalized medicine is key. What about the long lecture? Any more insights there?
The long lecture goes into more detail about why these dosage adjustments are so crucial when the kidneys aren't working properly. It explains that ciprofloxacin mainly gets eliminated through the kidneys. So if they're not doing their job, the drug can build up and potentially lead to side effects.
It's a great example of how microbiology and pharmacology go hand in hand when you're taking care of a patient.
Exactly. The long lecture also goes into specific dosage recommendations based on different creatinine clearance levels, which is another way to look at kidney function.
So it's giving us more specific guidance on those adjustments.
Right. And it reminds us that while guidelines are helpful, they should always be considered in the context of the individual patient.
It's all about using our clinical judgment, right? So listener, what are your thoughts? Do you agree with the Gemini advanced reasoning model that 500 milligrams of ciprofloxacin once a day is the right dose for this patient? Or do you share our concerns about potential toxicity with that low eGFR? All right, moving on to question 28. We have a case that really emphasizes the importance of knowing those bugs and how they resist antibiotics. We're introduced to Erysipelathrix rhizopatheae, a bacterium that's known for causing skin infections, especially in people who work with animals.
It's not as common as some of the other bacteria we see in skin infections, but it's definitely one to be aware of, especially in the lab or when we're dealing with patients who handle animals.
Our patient in this scenario is a butcher who's got a hand infection, which is pretty typical for this bacterium. The question asks us whether dalbavancin is a good choice for treating this infection.
Dalbavancin is a good antibiotic, and it works well against a lot of those gram-positive bacteria. It's often used for skin infections. But here's the thing about Erysipelathrix rhizopatheae, it's naturally resistant to vancomycin.
Vancomycin. But that's the one we rely on for so many gram-positive infections.
I know, right? It's kind of a quirky one.
So if it's resistant to vancomycin, what about dalbavancin?
That's where this question gets a little tricky. Dalbavancin and vancomycin are in the same class of antibiotics, the lipoglycopeptides. So if a bacterium resists vancomycin, there's a good chance it's going to resist dalbavancin too.
I get it. So the answer is no. Dalbavancin isn't the right choice for this infection.
You nailed it. This question is all about making sure we really understand those resistance patterns. We can't just rely on what a drug is typically used for. We have to consider the specific bacteria we're dealing with.
It's a great reminder that microbiology and pharmacology are totally interconnected. What did this short lecture focus on for this question?
It highlights that key fact. Erysipelathrix rhizopatheae is resistant to vancomycin. It reminds us that since dalbavancin is in the same class of antibiotics as vancomycin, if a bacteria is resistant to one, it's probably resistant to the other as well.
It's like they're saying, don't miss this. This is important.
Exactly. And the short lecture also explains why the other answer options are incorrect. It reminds us that Erysipelathrix rhizopatheae is gram-positive, not gram-negative, and that it doesn't have any special ways of inactivating those beta-lactam antibiotics.
So it's really guiding us towards that correct line of thinking. What about the long lecture? What did that add?
The long lecture for this one really walks us through the thought process step by step. It starts out by saying that dalbavancin is actually registered for treating skin infections, which might make you think it's a good option.
So they're trying to lead us down the wrong path.
Right. But then it hits us with that crucial info. Erysipelathrix rhizopatheae is resistant to vancomycin. And the long lecture points out that this resistance is actually mentioned in the source material, so we know it's important.
It's like a real-life example of how important it is to carefully read and understand those details in the source material.
Absolutely. And then the long lecture goes on to tell us that, according to Dutch sources, penicillin is actually the preferred treatment for erysipelathrix rhizopathia infections.
So we're not only learning what not to use, but also what the recommended treatment is, based on guidelines and expert opinions.
Exactly. And it even mentions that in many cases, erysipelathrix infections might just clear up on their own without any antibiotics at all.
That's pretty cool. So sometimes the best approach is to just watch and wait and let the body's immune system do its thing.
It's a good reminder that not every infection needs to be treated aggressively.
All right, listener, I'm curious to hear your thoughts. Do you agree with the Gemini advanced reasoning model that dalbavancin is not the right choice for treating this infection? All right, let's dive into question 29. This one focuses on optimizing our use of beta-lactam antibiotics, which are like the workhorses of antibiotic therapy.
It's all about maximizing their killing power while minimizing the risk of side effects, right? Finding that sweet spot.
Exactly. The question asks, which dosing strategy is best for increasing our exposure to beta-lactam antibiotics? We have 4 options. Shorten the dosing interval, but keep the dose the same. Extend the dosing interval, but keep the dose the same. Keep the dosing interval the same, but increase the dose. Or extend the dosing interval and increase the dose.
The key here is understanding how beta-lactams work. They're time-dependent killers. That means their effectiveness depends on how long their concentration stays above a certain level called the minimum inhibitory concentration, or MIC.
So it's not about giving a huge dose all at once. It's about making sure the drug concentration stays above that critical level for a long enough time.
Right. And to do that, the most effective strategy is to shorten the dosing interval while giving the same amount of drug each time.
So instead of one big dose every 8 hours, we might give a smaller dose every 6 hours.
Exactly. That way you can smooth out those peaks and troughs in the drug's concentration and keep it above the MIC for longer, which is super important for beta-lactams.
It's like providing a constant stream of antibiotic, keeping those bacteria under pressure.
That's a great analogy.
What did this short lecture for this question emphasize?
The short lecture keeps it simple. It just says that shortening the dosing interval while keeping the same dose is the most effective way to increase exposure to beta-lactams. It's a nice, clear reminder of that time above MIC concept.
Short and to the point. What about the long lecture? Did that go into more detail?
The long lecture actually does a nice job of explaining the difference between time-dependent killing and concentration-dependent killing, which we talked about with those other antibiotics. It points out that just giving a higher dose of a beta-lactam doesn't necessarily make it more effective.
So it's not about hitting those bacteria with the biggest hammer possible. It's about keeping them under pressure for longer.
You got it.
Yeah.
The long lecture even introduces a term, FTMIC. This refers to the percentage of time that the free or unbound drug concentration stays above the MIC. And this is really important because it reminds us that only the unbound drug can actually reach those bacteria and do its job.
It's like a deeper level of understanding about drug exposure and how effective it will be.
Right. And then the long lecture goes on to explain why those other dosing strategies aren't as effective. It points out that extending the dosing interval, whether or not you increase the dose, actually reduces the time above the MIC, making the antibiotic less effective overall.
So they're really emphasizing why shortening that dosing interval is the way to go.
Exactly. And the long lecture finishes up by saying that shortening the dosing interval while keeping the total daily dose the same, that's how we get the most bang for our buck, maximize bacterial killing and minimize side effects.
It's all about striking that balance. So listener, I'd love to hear your perspective. Does the Gemini advanced reasoning model's explanation for this question resonate with you? Does their focus on shortening the dosing interval make sense? And finally, we've arrived at question 30. This one takes us into the world of public health and molecular diagnostics. We're dealing with a lab that's using PCR to test for Shiga toxin-producing E. coli or STEC, which can cause some pretty serious foodborne illnesses.
It's a great example of how lab work connects to the bigger picture of protecting public health.
The question describes a scenario where the lab is testing for 4 specific genes: STIGS1, STIGS2, SEV, and E. And the question asks, if only one of those genes comes back positive, which one would trigger a report to the public health authorities in the Netherlands?
So we need to put on our detective hats and figure out which gene is the most worrisome, the one that really indicates a STEC infection that poses a significant risk to public health.
Right. It's not enough to just know that these genes are associated with STEC. We have to know what they mean clinically and what that means for public health.
Exactly. So let's take a closer look at each of those genes. First, we have STEC1 and STEC1/2. These are the genes that code for those nasty Shiga toxins, which are what really make STEC infections so dangerous.
Shiga toxins are no joke. They can cause anything from diarrhea to those really serious complications like hemolytic uremic syndrome or HUS, which can even be life-threatening.
You're right. Those Shiga toxins are the real troublemakers. And while both STEC1 and STEC2 indicate that the bacteria can produce these toxins, there's a big difference between them. Sex-STEC strains that carry the STEC2 gene tend to cause much more severe disease.
So STEX2 is like the one that sends up a red flag, while SEX1 is more of a yellow caution sign.
That's a great way to put it. When it comes to public health, STEC2 is the one that's going to get everyone's attention.
So based on that, it sounds like CIVCO2 is the gene we'd be most concerned about. But before we jump to conclusions, are there any other factors we need to consider, especially when it comes to those reporting guidelines?
Ah, you're thinking like a true microbiologist. And that's where things can get a little tricky, especially when we're talking about the Netherlands. You see, after 2016, the RIVM, which is the Dutch Public Health Institute, they made a change to their reporting guidelines for STEC. They started looking at isolates that only had the STEC1 gene a little differently.
Oh, interesting. What's different now?
The big change is that if STEC isolate is only positive for SINFITE1 and it's negative for SV, it doesn't have to be reported anymore.
Wait a minute. So even though STEC1 means the bacteria can produce Shiga toxin, they might not always have to report it in the Netherlands.
That's right. It might seem a bit strange at first, but that's the nuance of these particular guidelines.
So knowing the specific guidelines for your region is super important. What's the reasoning behind that change?
Well, the IVM looked at the evidence and decided that those STEC isolates that only carry stage T1 and don't have SDV, they tend to cause milder illness compared to those that have the stage EE gene. They just don't pose as much of a threat to public health.
I see. So not all STEC infections are created equal when it comes to how dangerous they are.
Exactly. The short lecture for this question really highlights the significance of that stage A2 gene. It emphasizes that stage A2 is the one we need to be most concerned about from a public health standpoint.
It's like a big warning sign saying, pay attention to this one. What about the long lecture? Did that add anything to our understanding of those reporting guidelines?
Yeah, the long lecture does a really good job of pointing out some of the trickiness of this question. First, it acknowledges that finding only one positive gene is kind of an artificial scenario. In a real lab setting, they'd usually test for all 4 genes at the same time.
So the question is more of a thought experiment to make sure we understand what each gene means individually.
Exactly. And then it goes on to remind us about that important change in the Dutch guidelines that happened after 2016. It really emphasizes that STEC isolates that only test positive for stage 1 and are negative for SEV, they don't need to be reported to public health authorities anymore.
It's a good reminder that guidelines can change based on what the science tells us and how we think about disease risks.
Absolutely. And the long lecture goes on to explain why those other genes, E and SV, even though they contribute to how virulent those STEC bacteria are, aren't enough to trigger a report on their own.
So it's really breaking down the thought process for us.
Exactly. Those genes aren't specific to SESCIN, so finding them doesn't necessarily mean that the bacteria are producing Shiga toxin, which is the main thing we're concerned about.
It's all about understanding the nuances of these reporting criteria, especially when it comes to a specific place like the Netherlands.
Precisely.
All right, listener, I'd love to hear your take on this one. Does the Gemini Advanced Reasoning Model's explanation for this question make sense to you? Does their focus on SECUS2 as the most reportable marker and their breakdown of the Dutch guidelines resonate with your understanding? Well, that brings us to the end of our deep dive into Exam A, questions 21 through 30. We've covered a lot of ground today, from different types of vaccines and interpreting serology results to those tricky antibiotic resistance patterns and the ins and outs of public health reporting.
It's been quite a journey through the world of microbiology.
And remember, listener, microbiology is a field that's constantly evolving. We're always making new discoveries and updating guidelines based on the latest research. So stay curious, never stop learning, and don't be afraid to challenge those assumptions.
And share what you've learned with your colleagues. The more we collaborate and share our knowledge, the better equipped we'll be to tackle those challenges in infectious disease.
We hope this deep dive has helped you feel more confident in your microbiology knowledge, not just for those exams, but for real-world scenarios too.
Remember, microbiology is more than just knowing those bugs. It's about understanding how they impact human health and using that knowledge to make a difference in the world.
Thanks for joining us on this exploration of the microbial world. Until next time, happy microbe hunting. All right, shifting